Hello, I'm Tony DeMaria, the editor of JACC. I'd like to tell you about some of the excellent articles we have in the July 31st edition of JACC. An important clinical question is, what's the best adjunctive antithrombotic treatment for patients undergoing PCI? That question keeps getting harder to answer given the new pharmacologic options available and growing concerns regarding the reported non-responsiveness of some patients to clopidogrel. The ISAR-REACT 4 study showed that among patients with non-STEMIs, bivalirudin alone resulted in similar ischemic events and less bleeding compared to unfractionated heparin plus abscizumab. Based on this well-done study, bivalirudin appears to have an advantage during PCI for non-STEMI patients pretreated with aspirin and clopidogrel. Now in JACC, we have the ISAR-REACT 4 platelet sub-study, specifically looking at the prognostic value of platelet function testing, particularly the identification of high on clopidogrel platelet reactivity in these non-STEMI patients. In analyzing the data, the prognostic value of platelet function testing depended on the adjunctive antithrombotic agent administered. Specifically, in bivalirudin-treated patients, platelet function testing was relevant for predicting ischemic events. That is, high on-treatment reactivity predicted the occurrence of early ischemic events. In contrast, in non-STEMI patients undergoing PCI on abscizumab and unfractionated heparin, high on clopidogrel platelet reactivity had little relevance. So the data suggests that stronger platelet inhibition, such as provided by abscizumab, is beneficial in non-STEMI patients who still have high platelet reactivity after 600 milligram clopidogrel loading. The benefit of antiplatelet therapy early in the process of acute coronary syndrome is well documented for those undergoing PCI, but its value is less certain for the 250,000 people for whom CABG is the preferred treatment option. We know the guidelines recommend early use of P2Y12 inhibitors in patients with ACS, but they also suggest delaying elective CABG for 5 or more days after the last dose of clopidogrel and 7 days after the last dose of prasugrel. Well, these guidelines are based on consensus opinions, and there are concerns that delaying CABG to reduce bleeding may come at the expense of increased myocardial injury, MI, and even stent thrombosis while awaiting surgery. So what should we do? In JACC, we get some insights from a retrospective analysis of the patients undergoing CABG in the TRITON-TIMI 38 trial. This is the first report of outcomes in patients receiving prasugrel followed by a CABG procedure and provides information about the relationship between residual antiplatelet drug activity, perioperative bleeding, and mortality. Overall, the results support the concept that an increase in residual antiplatelet drug effect increases bleeding and transfusion requirements. However, an increase in residual antiplatelet effect was also shown to be associated with reduced mortality in patients treated with prasugrel compared to clopidogrel. This was seen in spite of an increase in bleeding, platelet transfusion, and surgical re-exploration. All-cause mortality was 2.3% with prasugrel compared to 8.7% with clopidogrel. Now, one important point to keep in mind, since TRITON-TIMI 38 was designed with PCI in mind, this resulted in a CABG population enriched with 1 and 2 vessel disease. So the results are less generalizable to the typical population of patients referred for bypass surgery where 3 vessel disease predominates, or in patients who undergo complex or multiple operative procedures. Still, This study provides important information to surgeons and cardiologists as they determine the antiplatelet therapy to accompany PCI and the impact of this therapy on overall patient outcome if CABG is eventually indicated for revascularization. Despite all our advances in recent years, sudden cardiac death is still too frequent. We know ICDs reduce risk, but only 30 to 50% of implanted patients receive appropriate ICD firings, and up to 25% suffer side effects in the first year after implantation. Add in the financial burden of primary ICD implantation, and there's an urgent need to improve the benefit-risk ratio of ICD implantation. Clem and colleagues report in the latest issue of JACC on whether assessment of myocardial scarring by cardiac magnetic resonance would improve risk stratification in patients undergoing evaluation for ICD placement. In a prospective single-center study of 137 patients, the investigators found that in patients with an ejection fraction greater than 30%, significant scarring, defined as more than 5% of the left ventricle by MRI, identified a high-risk cohort for sudden death similar to the risk encountered in those with an LVEF of less than 30%. Conversely, in patients with an LVEF of less than 30%, minimal or no scarring identified a low-risk cohort similar to those with an LVEF of greater than 30%. While this study adds important information to prior reports in similar settings, it still does not provide definitive evidence on the value of LV scar assessment to help decide whether or not a patient needs an ICD. To answer this question will require a prospective interventional trial in larger cohorts of patients. For Inside JACC, I'm Tony DeMaria.